Hello, my name is Dr. Paul Finger. I'm the director of the New York Eye Cancer Center and author of the Eye Cancer Network, https://EYECANCER.com. Today I would like to speak about conjunctival squamous carcinoma, and in particular when either surgical or topical chemotherapy eye drops are indicated. Here are my CME disclaimers. This presentation, my research, and teaching work are supported by the Eye Cancer Foundation. I have no proprietary interest in the medications, technology, or devices discussed herein. Malignant ocular surface squamous neoplasia constitutes a spectrum of presentations or diseases. Starting from the least invasive to the most, there exists squamous dysplasia, squamous carcinoma in situ, which means within the conjunctival epithelium, locally invasive squamous carcinoma, which means when the cancer has invaded deep to the conjunctival epithelium, and cancer that invades either the eye or the orbit. Let's start with the essentials of the clinical examination. First, for all forms of malignant ocular surface squamous neoplasia, we must examine and photograph all conjunctival surfaces. Back when I started, we didn't even have digital imaging, but now it's all but inexcusable not to examine and photograph all conjunctival surfaces at presentation and then again at each follow-up visit. Why would you want to do this at each follow-up visit, you might ask? Well, photography can be used for definitive documentation of new, regressed, recurrent, or previously occult disease that may occur anywhere on the conjunctival or corneal surface. For example, how can you tell if there's a new lesion if there's no old photograph from which to compare? You can see here a demonstration of poses that include all conjunctival and corneal surfaces, including with eversion of the upper lid. The same is true for gonioscopy and goniophotography, as well as for high-frequency ultrasound imaging called UBM, where 360-degree examinations are performed for each quadrant and photo-documented. In summary, at the New York Eye Cancer Center, I require that the entire conjunctiva and cornea be examined and photographed at presentation and repeatedly at follow-up. Particular attention is made to examining the cornea for opacification and vascularity. Anterior segment photography is used to document and follow patients for tumor regression and for their recurrence. Both the patient's cervical and preauricular lymph nodes should be palpated for evidence of enlargement. In addition, if the punctum is involved, ask your patient if they have unilateral nasal stuffiness, and if indicated, palpate the involved lacrimal drainage system. If orbital disease is suspected, Hertel exophthalmometry, color plates, and CT imaging is employed. I obtained total body PET-CT imaging for all tumors larger than a lima bean, or typically AJCC categories CT3 and CT4. Now, back to the basics. For minimal disease, there exist two main conjunctival variants. The first and perhaps most common is the diffuse variant, where there are corkscrew vessels and a horizontal growth pattern. Most diffuse tumors are located at the limbus with feeder vessels on one side and corneal extension on the other. Careful examination will likely reveal the anterior edge of relatively clear, avascular and opaque tumor, perhaps the best demarcation line of tumor extension that exists. That pale tissue would be much harder to see overlying sclera. The diffuse variant can masquerade as chronic conjunctivitis, especially when tumor formation occurs late in the disease. This is another reason to biopsy chronic conjunctivitis or chalazion. Moving on, there is a nodular squamous carcinoma variant. Nodular disease is similar to the diffuse with respect to corkscrew vessels and perilimbal location. However, there is a unique vertical growth pattern and less cortial extension. On its surface, desquamated squamous cells can appear white and caked. Vertical growth goes in both directions. Therefore, the nodular form is more likely to invade the eye. On your right, we see histopathology of a tumor that grew, blunted the angle, and invaded the supraciliary space, leading to uveal thickening. This pathology will be mirrored by later pictures of high-frequency ultrasound imaging. As promised, here we have an example of the relatively low reflective ocular surface malignant squamous neoplasm causing angle blunting and uveal thickening. The invaded sclera beneath the tumor also appears dysmorphic. I've always been fascinated by high-frequency ultrasound imaging, as it was an indispensable tool for my ocular tumor practice. I found ultrasound to be indispensable for the diagnosis and treatment of ocular surface malignant squamous neoplasia. In fact, I wrote this multi-center paper back in 2003 examining the characteristics of this disease, and in general, its results led me to understand why UBM should be performed on each and every patient on each and every visit. Though the yield is low, 5%, are associated with intraocular invasion. Alternatively, if you don't have a UBM, the Q-tip test can be used to see if the tumor is mobile or not affixed to the eye wall. This suggests that it's not invading. The importance of gonioscopy might be as subtle as this case, where there are anomalous blood vessels in the involved angle, suggesting intraocular invasion. However, in many cases, you may actually see a tumor mass and its effects on angle tissues. So here are a couple heresy questions. It's always need to have a couple heresy questions in every lecture. Do I need to know if there is invasive carcinoma on histopathology? How will that information affect my treatment recommendations? What is the legality of not getting a biopsy? How good is the clinical exam for making the diagnosis? Does the treatment require that I know the diagnosis? Well, with the risk of going afield for this lecture, let's consider that patient by patient, sometimes we may require a definitive answer or second opinion by the pathologist. Further, we must understand the limitations of our diagnostic techniques. Perhaps this is a second reason for all those 360-degree photographs, ultrasounds, and gonioscopies. Also, that histopathology may rule out an alternative diagnosis. Perhaps with more invasive treatments that come with higher risks, we should more likely do biopsies. And conversely, with less invasive treatments, with low risk, we may not need to. Obviously, I'm asking all these questions because the next part of my lecture gets into my transition from operating on most of my patients with malignant ocular surface squamous neoplasia to the use of the relatively non-invasive and lower risk topical chemotherapy. Clearly, the advent and my experience with scrape cytology, biopsy, made my transition to topical chemotherapy easier. Here, we use scrape cytology to establish that the tumor cells were indeed malignant. As you can see on the bottom rows, there's quite a difference between pathology or histopathology and cytology. clearly tissue is required to establish the diagnosis of invasive disease. However, cytology can be used to establish that the cells are malignant. Here's another case. Few of you in the audience would consider that the tumor above was anything but malignant squamous ocular surface neoplasia. On the bottom, we see that the scrape biopsy shows multiple cells, but does not show the behavior of those cells as they may or may not invade. On the right, however, we see histopathology, which gives us both cells and their behavior as invasive or non-invasive. Note the pros and cons of scrape cytology versus biopsy. The pros are that it's an office procedure, it's low risk, you can get cells and even small chunks of tissue and establish the diagnosis of malignancy. However, you cannot assess invasion and you cannot assess margins. In contrast, surgical biopsy offers histopathologic evidence of subepithelial, scleral, intraocular, and even orbital invasion. In addition, I have described the use of minimally invasive aspiration cutter-assisted biopsies, either under helon for the anterior segment or into the orbit. So back to the title of this talk. What is the role of surgery for ocular surface squamous carcinoma? My current surgical indications include tissue biopsy for invasive and atypical tumors. I use surgical biopsy for invasive epibulbar tumors in order to assess the sclera and/or uvea, typically for adjuvant cryotherapy or radiation. I also use surgical excisional biopsy when the patient does not prefer topical chemotherapy. Lastly, occasionally orbital exenteration is required. This is typically with adjuvant radiation therapy to save life. When I perform primary surgery as treatment, I use adjuvant cryotherapy to the deep and peripheral margins unless the tumor has invaded the globe. Back in the day, I convinced a couple of companies to make large spatulated cryotips because rather than making overlapping cryo dots, large size spots allowed for less overlap without missed areas. I prefer to treat large surface areas at one time. The following brief movie will show you such a treatment. The smaller version of the spatulated cryotip was used for additional margins after resection. It can be done from the inside out or the outside in. Here you see the resection margin and the cryo margins being added. Sometimes the tumor is just too large for excision, cryotherapy, and even radiation therapy. This 8th edition CT4 category stage ocular surface squamous malignant neoplasm was found to be localized to the orbit. That is, there was no evidence of metastatic disease either in the cervical chains or on systemic evaluation by PET-CT. Therefore, he underwent a primary exenteration with post-op external beam radiation therapy. So my old surgical paradigm was excision for small unifocal AJCC CT1 category tumors. I would excise the entire tumor plus 2 millimeter margins of a normal appearing tissue, and then I would apply cryotherapy to the episclera and add an additional 2 to 3 millimeters of cryotherapy margins. In the cases where the tumor was not resectable, I would use cryotherapy or more likely add topical chemotherapy for the unresectable portions. Otherwise, unresectable tumors would go to exenteration with adjuvant radiation therapy. My new paradigm is that most cases can be cured by topical chemotherapy alone. This leaves few cases that require surgery. These are occult invasive or more likely recalcitrant tumors. This new paradigm does not apply to ocular or orbital invasive disease. As you can see, I've done a lot of research on the use of topical chemotherapy for ocular surface cancers beyond the scrape biopsy and high-frequency ultrasound work. This experience has led me to continually try to push the envelope and treat more and more patients without surgery. This slide describes the action of alpha interferon for ocular surface malignancies. Unfortunately, this medication is no longer available by Merck, though there is some current interest in an alternative pharmaceutical company picking up that baton. Simply, interferon boosts the host immune response, which is anti-proliferative for tumor cells. I use this mechanism to alert the immune system that local eye cancer exists during immunotherapy for unresectable and metastatic conjunctival melanoma as well. The more commonly used drug is 5-fluorouracil. Its mechanism of action is to prevent DNA synthesis. I explained to the patient it's like putting a lock on mitosis, as seen in the upper right graphic. The ophthalmic solution of 5-FU 1% is instilled 4 times a day for 10 to 28 days. It's quite effective, but a bit more toxic than interferon. It's also a bit less expensive than interferon. I suggest you think of mitomycin and 5-FU as cousins. Mitomycin also affects DNA synthesis and locks that wheel. Either continuously or in two-week courses, mitomycin 0.02% is commonly used at the New York Eye Cancer Center. I prescribe it more commonly for conjunctival melanoma as compared to ocular surface squamous neoplasia, though I have used it for both. There exist special procedures for topical chemotherapy. For example, a plug should be placed to prevent the medication from going into the punctum and causing mitomycin or 5-FU-induced stenosis and secondary epiphora. For interferon, the punctal plug prevented systemic absorption and thus flu-like symptoms. However, at home, drop installation and safety are also important, and therefore we created a video for patients to better understand how to place the drops. It's on YouTube and Vimeo, so it can be played in the office, but also at home for patients.
Hi, I'm Dr. Christina Olszewski.
And I'm Dr. Sonal Chagule.
And Dr. Chagule will be our mock patient for today. we're going to be going over how to instill chemotherapeutic eye drops. These instructions will be the same regardless of the eye drop that you're taking. You're going to be putting 1 drop in the affected eye 4 times a day while you're awake for the directed amount of time. Most people do put the drops in themselves, but if you prefer to have someone else put them in for you, that's okay. Just make sure that they follow these same instructions. Please keep in mind that these drops must stay refrigerated at all times. So if you're leaving your house for the day, just keep them in an insulated bag with some ice packs, but do not put them in the freezer. Okay, let's get started. Step 1, wash your hands and put on latex gloves if possible. Step 2, lie down flat or recline back in a chair. Step 3, look down and pull back the upper eyelid. Step 4, put the drop on the top part of the eye. Step 5, slowly close your eye and keep it closed for 5 minutes. Step 6, make sure to gently wipe away any excess. Step 7, if you did not put on gloves, then wash your hands again. Although it's common to have some irritation in the eye when using these drops, if you're experiencing any eye pain, blurred vision, or flu-like symptoms, then be sure to give us a call at the office.
So what are topical chemotherapy complications? In review, both topical 5-FU and mitomycin cause blepharoconjunctivitis and can cause corneal edema. The most common side effect associated with interferon is flu-like syndrome. Blepharitis and flu-like symptoms abate upon cessation of the drugs. So now that we have learned the mechanism of action and the possible side effects, we're all ready to treat some cases. None of the next series of patients had clinical evidence of intraocular invasive disease. The first set of patients all had what I call minimal disease, or AJCC, CT1, and some CT2 cases. In this first case, pre-treatment imaging can be seen at the top and the lower left frame. After 3 months of topical interferon alone, and then 2 years of observation, the patient remains without evidence of active disease. Here's a case of what was a easily resectable with adjuvant cryotherapy, ocular surface malignant squamous neoplasm. However, the patient opted for topical chemotherapy, and after 28 days of mitomycin 0.04%, the tumor had resolved and did not recur prior to discharge. I had this case, which also had minimal disease. After 2 months of interferon, the tumor had melted, and the eye stayed without evidence of recurrence, and the patient was discharged back to the local ophthalmologist. So far, we've seen several cases where only one chemotherapeutic agent was used. Here we have an example of sequential polypharmacy, where one chemotherapeutic agent is abandoned and replaced with another. First, we started with interferon, and after 5 weeks, the tumor was only slightly improved. Therefore, I switched to 5-FU 1%, and after 4 additional weeks, there was no evidence of residual cancer. This case demonstrates that you don't have to quit after one form of topical chemotherapy. Here's another case of polypharmacy. On the left, we see the before treatment photograph of a nodular tumor. After 1 month of interferon, it did not appear that there was any effect. However, after 2 weeks of mitomycin, the eye was completely clear and the vision returned to 20/20. So what about even large conjunctival squamous carcinomas with no evidence of intraocular invasion? Can chemotherapy alone lead to chemotherapy cure? On your left, you see a rather diffuse ocular surface squamous carcinoma which had failed topical mitomycin chemotherapy. Then the eye was treated with 2 weeks of 5-FU, and 95% of the tumor had melted away. But it wasn't until the last 3 months of interferon that I felt the eye had stabilized without evidence of tumor. In this case, we started with 5-FU and then transitioned to mitomycin. And finally, at 8 months, the patient had turned 80, enjoyed 20/20 vision, and was ready to return to his general ophthalmologist. Here we have a case of a classic nodular ocular surface malignancy. It was treated first with interferon, found to be resistant, and followed up with 5-FU 1% until it regressed to a conjunctival corneal scar seen on the bottom right. Lastly, we have a case of a rather large epibulbar diffuse malignant ocular surface squamous carcinoma. Here we see no ultrasonographic evidence of intraocular invasion, and with long-term topical chemotherapy, that is without any surgery, even this tumor was controlled. So let me leave you with some guidelines. First, rule out intraocular invasion. Then you can treat with topical chemotherapy. This may be monotherapy or polypharmacy. You could start with 5-FU, as I do, and then transition to mitomycin if need be. If neither works, there's always excision with cryotherapy. So what can we learn from this talk? Topical chemotherapy has become a first-line curative treatment for most malignant ocular surface squamous malignancies that present in developed countries. There exists no standard presentation nor protocol for their treatment. In fact, indications are evolving and less directed by tumor size or morphology. Tumors with intraocular invasion are not typically treated with topical chemotherapy, as it has not been shown to penetrate the eye sufficiently. As compared to treatment by excision and cryotherapy, both corneal stem cell deficiency and symblepharon are rarely seen after topical chemotherapy. Thank you, and have a nice day.
I'd like to take a moment to thank the Eye Cancer Foundation for supporting our research and educational initiatives. We were the first to develop international multi-center cooperative research. We want to help you, your children, and families around the world. Please consider visiting our website, eyecancercure.com.